Good morning, everybody. My name is Glenda Drake. I'm from Banner University Medical Center in Tucson. And today, hopefully you're in the right place. We're navigating the pregnancy experience, PT and RT best practices. We have some amazing speakers today. And I'm really proud to have them all here today. This is Michaela Green, my co-partner.
Yeah, I'm a physical therapist by trade. I am from the Adult Cystic Fibrosis Center of Austin, Texas. And my slides aren't presenting, but the presenter's slides are working, so that's what matters. Mm-hmm.
We have no disclosures.
Yes. So the session will explore part of the multidisciplinary team approach and explore the impact of pregnancy and parenthood on health with people with cystic fibrosis. In the age of effective modulators and improving therapies, the number of pregnancies and life expectancy has increased within these populations. This gives physical therapists and respiratory therapists an opportunity to expand upon our skill set and help our patients plan for their futures. So our speakers will include patient experiences, current best practices based on current research being conducted, and future potential impacts on the care for these individuals with CF.
And also remember, everybody, that on your app, you can start writing questions. We'll have them here for each speaker, or at the end, we'll have some other time for questions and answers also, okay?
Yeah. So at this time, I'm going to invite our first speaker, Christina Richter. She is a registered nurse for the Adult Cystic Fibrosis Center of Central Texas. Her love of working with patients with cystic fibrosis started in January of 2003 while working as a patient care tech on the respiratory unit in Seton Children's Hospital of Austin. After graduating nursing school in 2008, she continued to work on the respiratory unit until 2013. She rejoined Ascension Seton Medical Center in 2020. Since then, she has participated with her team in quality improvement initiatives such as the VIP F8 and has contributed educational resources regarding pregnancy that were accepted to this year's CFF Resources Guide. Christina continues to attend various local CF Foundation chapter events and is an active member in the Central Texas CF community. This year, she was selected as one of Austin's finest honorees for the Central Texas CF chapter. And I get to work with her, so I'm pretty excited to hear what she has to say.
Good morning. Thank you so much for having me. I'm so honored to be here speaking with these fellow speakers. Let me just get going here. I have no disclosures to report. So I'm going to be discussing today the pregnancy experience for people with CF or individuals with CF from their perspective. And since the introduction of Trikafta, we as care providers have learned very quickly how to treat these patients that have cystic fibrosis and have become pregnant with this baby boom. When I was thinking about what I wanted to present today, instead of talking about what I think and what I do, I wanted to really share the perspective from an actual patient. So I'll be sharing videos today of one of our patients at our clinic and just questions that I asked her. So this is Jessie. We asked Jessie. One, she's honest, she's relatable, she's hilarious. Two, she was the very first pregnant patients that we took care of. So she was part of that initial, oh wow, here we go. Group of people. And so we actually she was one of 4 patients that delivered within a month of each other in October of 2020. So she was right there on the ground floor with us. And finally, she agreed. So without further ado, meet Jessie.
I'm Jessica Coulter, but I go by Jessie, and I am 38, sorry. I live in Austin. I've been here about 13 years with same care team throughout, mostly, and I have a 3-year-old whose name is Wyatt.
Wrong button. So I broke up this interview into sections. I did pre-pregnancy, pregnancy, post-pregnancy. I put some RT considerations, so that's in there. And then finally, what I think is most important, Jesse's writers. Also disclaimer, I'm not a professional journalist, so please excuse the subpart interview techniques.
So what did you expect or think the experience would be like being pregnant?
You hear a lot of, stories from other people, and pregnancy is portrayed in the media, but almost zero of that is cystic fibrosis specific. So, that already skews things. And then I got pregnant in February of 2020. So then immediately the world shut down, and I was just in my house the whole time. So, whatever sort of, dancing around in the grocery store and people trying to touch my belly, maybe like none of that happened. I kind of thought that I didn't really know that I would just sleep through the first trimester, just like straight up, because my mother had told me like, oh, I was so tired all the time, but like, I didn't really take that in the way that she probably meant. So that was kind of surprising. And actually the pandemic kind of helped me in that way, because I got to be at home and just work from home, but really legit just the whole first trimester. Did not expect that.
And so pre-Trikafta, did you always see yourself as a mother? Did you always want to have kids?
Yeah, I mean, it was kind of in the back of my mind. And then the older I got, when I started like hitting mid-30s, I started thinking, okay, this needs to happen, because I'm not getting any younger.
And then as far as family planning goes, what was your experience like with that?
So I had a hard time getting pregnant, and we spent maybe a year and a half with nothing happening. And then we ended up going to a fertility clinic. So, we tried to plan a family, and that didn't really work out the way we thought it would. And then we went to one fertility clinic and had a bad experience with that doctor. And then we went to a different fertility clinic on the recommendation of a friend, and that worked out way better. And it wasn't full IVF. We did, I forgot what it's called now, IUI, I think. We did 2 rounds of that, and the second round worked, and that's my child. So, things kind of went sideways a little bit. And I had talked with my doctors about maybe going on. Trikafta was available then. They were like, you could go on it to help. But there wasn't a lot of research. Like, we didn't know if that was okay or not. And I just opted not to. And now if I had to do it again, I think I might have told my myself just go on it, because I think it would have made things easier. But,
So as you heard, Jessie did not take Trikafta while she was getting pregnant, and she's going to discuss her thoughts about what she wishes she would have done and what she did do a little in the next couple of segments. Her pregnancy experience.
So after you got pregnant, what was your experience like during your pregnancy?
Health-wise, it was kind of up and down. I was okay until I would say the middle of the second trimester. I don't know if I can remember like getting a cold, but like I had some sort of exacerbation and couldn't take the medications that I normally take, and it ended up being this whole thing where I had a PICC line and doing antibiotics, and that kind of carried us. Then I got a blood clot because I was pregnant. We had to take the PICC line back out, and so we just sort of limped along until I also had, I forgot what it's called, the placenta previa, that thing. And so Wyatt had to come out early, like almost a month early. And so we like kind of limped along with me just going like, trying to stay healthy as I could, and then had a C-section. He came out. So, the leading up to about the 7th month was okay. And then it got kind of rough.
Yeah.
And I had a fair amount of hemoptysis. I can never say it right.
Yeah.
Hemoptysis, because my fertility doctor had me taking baby aspirin. I forget why. Maybe for the blood clot issue. But then I started coughing up blood, and he was like, "Okay, don't take the baby aspirin." So it was a little bit of a roller coaster. I think now if I took Trikafta and got pregnant, it would probably alleviate a little bit almost 100% those issues is my guess.
So on that same token, how did your body change throughout your pregnancy in ways that you expected or maybe didn't expect?
I'm trying to remember if there was anything unexpected. I had a big baby, which was the other thing. My husband, when he came out, was like a 10 plus pound baby, and so we expected mine to be big. And they did have gestational diabetes, so by the time Wayne came out a month early, he was already over 7.5 pounds. So I was big, and I didn't really have that much trouble gaining weight. It was hard to do that with the gestational diabetes diet, though. The funny part was, like, as I was gaining, my husband was losing weight. We were eating so much healthy. Like, we cut out all the carbs and no sugar, and he looked great by the time I was born.
How about like lung function? When the Wyatt was growing, how did that affect like your ability to do your treatments and your ability to breathe? Did you expect it to feel that way?
I guess I didn't know what to expect. I'm a little bit too much of an optimist, just so I always go into things like, oh my God, even if it won't. I was still using the inflatable vest at that point, so I was able to just keep doing that the whole time. I think I had the Monarch at that point, but I just quit using it probably as soon as my stomach started to grow. I think I felt okay, but I remember, when I got sick towards the end, I felt less good. And I remember going on a walk with one of my friends who had been pregnant, but her kid was out by then. And she's already a fast walker, and so she usually has to like wait for me to catch up. But this, I was like, I think you gotta walk slower. And then I thought, oh, maybe this isn't great. This isn't great. And then when I got that PICC line and started getting antibiotics, I felt actually way better. And I was like, oh, I didn't realize how bad I felt. It kind of crept up on me, And then when I got the antibiotics, oh, this is how I should have been feeling the whole time. So it was easy. It was kind of like a frog being boiled in water.
Yeah.
It didn't jump out.
Yeah. So then with talking about like the antibiotics and stuff, what additional support did you feel like you needed from your CF team that you might not have needed if you weren't pregnant?
Oh, there was a lot more phone calls. And I feel like we were tracking things more. Like, I think I had, also it was the pandemic. So it's all sort of like, y'all had sent us the home spirometers. And so I had that data. And
was that helpful to have?
Yeah. Actually, in Austin, mostly what it showed is when it rained, I did better. Because you can track like the weather report. Because I also, Austin's the allergy capital of the universe. So that was kind of a compounding factor. I had been doing allergy shots, and I had just finished them right when I got pregnant. So we couldn't tell if, was I regressing from the allergy shots? Was I pregnant? Was I not pregnant? What's an infection? What's not an infection? So it's a big mess.
Sure. Just lots of questions and unknowns, for sure. And then what challenge?
We're going to move on to PT-RT considerations when pregnant.
Okay, so when you were pregnant, before you got pregnant, what did your exercise routine look like? And then as you progressed in your pregnancy, how did that change and what did that look like for you?
I used to ride my bike a lot, so that was a significant part of my exercise regimen. And cardio dance classes and yoga, stuff like that. Probably I would ride my bike a couple of days a week and then do some yoga sporadically and then do cardio dance sporadically. But I'm also kind of a DIY person, so on a weekend, I'm not really sitting on the sofa, I'm doing projects. And we used to have a community garden plot, so we go to the garden, so it's pretty active. And then when I got pregnant, I don't know, as aforementioned, I slept through the first trimester. But as I came out of that, because it was during the pandemic, I could still ride my bike, but I did not ride my bike while I was pregnant because I did not want to get hit by a car. So I was mostly at home. I have a friend who does kooky sort of Richard Simmons style dance videos, dance classes, and she was streaming them during the pandemic. So I did a lot of those. And then she recommended the Fitness Marshall on YouTube, and he does also goofy dance class videos. That was mostly what I did during the pandemic. I think I did some yoga too. I got the opportunity to go to exactly 2 prenatal yoga classes before COVID shut everything down. And that I mean, I would take walks with my friend outside, but because it's Austin and that was sort of July, August, September, we kind of quit doing that because you could only go out in the morning.
So do you prefer to like do your walking, but as you know, as the season progressed here, it was kind of intolerable?
Yeah, and then I think when I got sick was probably like August, and then in no way did I want to be outside in the heat with my sick self. So
And did you notice when you were, as your pregnancy progressed and you were able to exercise, did you notice yourself getting fatigued earlier? Did you feel your heart rate rising faster?
yeah, I don't think it super affected me until that August dip when I had the exacerbation.
Okay.
I think it was fine up until then. It's been 3 years.
Yeah. But you felt comfortable like being like, okay, this is where I need to stop. This is where my body is telling me
Yeah.
this is enough.
And, because we were home all the time, I had plenty of time.
Yeah.
So even if it was just a little bit here and there, I could do more, like I could do shorter bits of exercise more frequently.
Did you find that was easier on your body?
Yeah, and I kind of have a short attention span, so that was better for me too. Like, I'm not going to sit here for an hour doing anything.
And so
Yeah.
pre-pregnancy, did you use air or exercise as a form of airway clearance?
I really tried to do my best twice a day,
Okay.
and then exercise was bonus.
Okay. And so as your pregnancy progressed, did you find that you needed to add an extra airway clearance?
I was
Best
doing
session,
that. I think I started throwing them in the middle of the day when summer hit, and it was hard.
So while you heard, or as you heard, Jessie was very good at doing her airway clearance before she got pregnant. And she kind of alluded to that too, at having the pandemic and being able to have those extra sessions. Yes, I wanted to mention that. Okay, next slide.
So care team, what did they do in working together? What worked well? What did you find beneficial?
I had my OBGYN already, and then once I got pregnant, she sent me over to a maternal fetal medicine doctor, and I saw him probably more than I saw her because they were doing fairly frequent, what do you call it, the 3D,
Ultrasound.
thank you, ultrasound, which is kind of cool because, most people don't get those on the regular, but I have like just a box of printouts. It was fun. And he was great. And then I had, at the hospital where I was going to deliver, they have a program where they assign you a nurse in the maternity ward, and she contacted me way ahead of time to sort of sort out who was going to handle what in the hospital and what my medications would look like. And she was just the point of contact, which was fabulous. And I hope everybody has access to that because she was really great. Like, I could contact her directly with questions I had beforehand, and then she talked to y'all, my regular care team, and we had like a phone conference call where we all just sort of planned out what the week of me being in the hospital was going to look like, because I had a planned C-section, so that was kind of easy to plan ahead of time. And then she was there physically in the room when Wyatt came out, and she was there afterwards. So like just having like a person who knew my case, knew the medications, could be the point of contact, that was like wonderful. I had totally forgotten this until just now. Being in the hospital growing up, I kind of had in the back of my mind, like, they're not going to bring me enough food when I am in recovery because I'm going to be super hungry, because I was pregnant and hungry all the time. Like, that's my main concern on that phone call with her. I was like, I'm going to be hungry. You need to make sure I get enough food. And so she noted on the little thingy, like, double portions of food. But this particular hospital absolutely provides plenty of food. Like, it was like, I was picturing like they're gonna send me a PB&J of like applesauce. I'm like, I need more. But they had like a lovely menu, but the messaging with the cafeteria got messed up. And so at one point, like, I asked for lunch and they sent me not one, not two, not three, but 4 burgers. Because she had written down to double all the portions, but then somebody in the basement had doubled the double. And so Jason and I were sitting there like, how do we make it stop? It just kept piling up. So she did too good of a job in that respect.
So it's nice to have somebody that you could talk to about things that were maybe like not widely known, like diet, for example. Like, how are you going to get your food? What's it going to look like? It was nice to have that point of contact.
Yeah, and she, like, you know, I had respiratory therapists filtering through, and I had nurses filtering through, and the shifts change. You know, there's new people, and not having to explain to every new person everything was nice. And she hooked us up, because at St. David's they have like a bunch of rooms, and then they have some slightly bigger rooms, and one of those slightly bigger rooms was unoccupied, and she was looking around at, like, they had parked the vest machine in there on a rack, and we were just like, you know, the baby was over here and Jason was over here, and she was like, y'all can't move in here, and I was like, I know. So she got us into a bigger room just to like fit all the stuff.
Okay, so
which was
having
great.
more space would be helpful to moms
Yes.
postpartum with their vest and all the things. Okay. Any other final thoughts you want to share?
I mean, I'm glad we did it, because I had my lovely son. It was a lot. I think being on Trikafta from the front probably would have helped. I don't know, you know, hindsight's 20/20, and maybe it was the right decision at the time. But just being as healthy as you can be going into it is probably a good option. And then now, it's given me more brain space and time to devote to raising him. So I don't know what I'd do without it. So, yeah.
Thank you so much, Jessie.
Thank you.
Appreciate it.
So just briefly wanted to highlight what we as a CF Care team did on the back end. Lots and lots of education creation that we worked on. We made a CF general education handout for the OB and the MFM providers. Easy to read. It just basically on a very low level discussed vitamins and enzymes, treatments, what CF is. And then another really important part that we put on there was easy to read genetics, because we had patients coming to us saying, oh, my OB told me that my baby's going to be a carrier, or my baby's going to have CF even though the dad was negative for having any mutation. So we learned really quickly that that was a lot of misinformation out there. So, and that is actually, just a shameless plug here, that is actually in the resources guide here at NACFC if you wanted to take a look at that top one. We also scheduled care conferences to have the full team on board, which you heard Jessie talk about. We would have MFM, OB, the LND navigator, which is the person that Jessie was referring to, just to have everybody discuss, know what's going on beforehand, so there's no surprises. We also created a CF inpatient recommendations for the OB to have in the LND and postpartum ordering process. So things that they don't understand or they don't regularly do, isolation precautions, their own stethoscope, double portions, as Jessie alluded to, enzymes at the bedside, treatments, that whole thing. And then we also provided contact information to the OBs for our full team. So RD, RT, PT, nursing, nurse practitioner, they got all of our information. I'm sure if there's any RDs in the room, but we had a lot of issues with vitamins, like the OBs don't like to give that vitamin A. So we had a lot of good discussions, and having that open, easy access for communication was really key for us. We also provided education relating to airway clearance techniques, and then also having a PT knowledgeable in pregnancy was key for us. Finally, I am going to show you probably the cutest slide that you will see all day today. I just wanted to share with you Jessie and her son Wyatt. These are the pictures she sent over. We just love him in the clinic. He is just the absolute cutest. So. If you have any questions, please feel free to reach out to me. I'll put my contact information down there at the bottom as well. We have all of our information, our education handouts saved, obviously. So if you'd like a place to start or you just want some information, I'm happy to share what we have. Thank you so much. Good.
We'll hold questions for the end.
Okay, our next speaker is Dr. Jennifer Taylor-Cousar. She is a tenured professor of adult and pediatric pulmonary medicine at National Jewish Health. She serves as a medical director of the Clinical Research Service, president of the medical staff, and co-director of the Adult CF program and director of the CF Therapeutic Development Network, or TDN. She received her undergraduate degree in human biology from Stanford, and that was in 1993, and completed her doctoral in medicine in 1998, combining residency in internal medicine and pediatrics in 2002, and her combined fellowship in adult and pediatric pulmonary medicine in 2006 at Duke University. She obtained her master's of clinical science from the University of Colorado in 2015. Needless to say, she's an overachiever, but that's great. We still love her. So thank you again for Dr. Taylor-Cousar.
I think what she actually just told you all is that I'm old.
Okay. Okay, let's see, they're not really clicking up here. Why? Oh, no, that's actually looking like hers instead of there, and then start. Beautiful. Nope, that's still hers, yeah. Thank you for being patient with technical difficulties. Okay,
Thank you. So thank you both for the opportunity to speak today. I think it's really exciting. There's Imogen. So Dr. Imogen Felton, who's done a ton of work at her center when everyone started getting pregnant, noticed that she got to go to a pregnancy session every day. So I think that's a really exciting time that we're in, that's happening here at NACFC. So these are my disclosures. The most relevant one for this one is that I'm the co-primary investigator on the Mayflower study. So we have funding from the CF Foundation for that, as well as for the sharing group. So the main objective really is to incorporate the knowledge of the impact of pregnancy on physical and mental health of people with CF. And I think it's really, it's going to be a disclaimer. We don't have a lot of information about the mental health of women with CF when they're pregnant. And so you'll hear a little bit at the end from the Mayflower study, but it's definitely a gap in the literature. So as you all are well aware, the majority of people are eligible, at least in the US and other high-income countries, and taking highly effective modulator therapy, but not everybody is. And so I think that's important to keep in mind. And some people are choosing, as you heard from Jesse, not to take modulators during pregnancy. The one thing I continue to emphasize because of all the unplanned pregnancies that we've seen is reminding everybody about fertility in CF. So the majority of males with CF are obviously infertile because of congenital bilateral absence of the vas deferens. And there is no evidence that unless you receive highly effective modulators while you're in utero as a man that you're going to have fertility. But women with CF or females with CF can definitely have increased fertility because there are CFTR channels throughout the cervix, and those respond to highly effective modulators quite well. So there are possibilities that people are healthier, and that's partly contributing to why people are having easier time getting pregnant, but we really think it's the effect on the cervix. So there was early evidence of that. And in fact, back in 2014, I worked with Sonia Helchi at the TDN to look at the impact of pregnancy or modulators on pregnancy. And we saw that during the ivacaftor trials, there were less pregnancies because, of course, people were required to be on contraception. But right after that, those who had G551D and were on ivacaftor had this bump. So we were expecting this boom to happen with Trikafta. So there's also a study that showed that it was done down in South Carolina, I believe. They actually looked at people right after Trikafta got approved and showed that people were getting pregnant within 3 months of being on Trikafta, even in the setting of not having been able to get pregnant before. And I think this actually shows you quite well and goes along with Andrea Rowe's data showing that there are changes in the cervical mucus after highly effective modulator. At the top shows what it looked like before the woman was on ivacaftor, and the bottom is what her cervix looked like afterwards. So it does really make a difference. So we must counsel people, including teenagers that are going on this drug, that they can have an easier time getting pregnant. So, of course, as I mentioned, we were sort of expecting the Trikafta baby boom because of what we saw with the ivacaftor data earlier on. And we have seen that not just in the US, but all over the, again, high-income countries that have this drug available. It's also really important, and you heard from Jesse, that there are changes during pregnancy. And so even if you don't think about CF, there are lots of changes. And of course, as a pulmonologist, I'm going to think mostly about the cardiology and respiratory changes. You're going to hear a lot more about the respiratory changes from Brenda Button later. But of course, GI changes occur as well. And women with CF are constipated before they get pregnant, and that can get worse. Obviously, many women with CF have CF-related diabetes. That's also going to get exacerbated during pregnancy. So there are a lot of changes that happen during pregnancy that are going to be exacerbated because of someone's CF. So I also think that it's important to consider the historical knowledge that we have about what's gone on in pregnancy in women with CF, because again, some people don't qualify for modulators. Some people are going to choose not to use them during pregnancy. So we also want to know, are things changing for those who are on modulators? But we do need to consider what we know from the past. So Goss and colleagues used the US CF patient registry to look at people who became pregnant and those that didn't. And he actually showed that there were people who were healthier at baseline who chose to become pregnant, which kind of makes sense. If you're really sick, you may think that isn't a good idea. And in fact, we counseled people who had lower lung function, 50 to 60%, not to get pregnant back in these days. But those people had a healthier lung function at baseline and a better 10-year survival. And I think those things go together. So they were healthier at baseline, they survived longer, but also if you talk to moms with CF, they were thinking about their health before, but they're thinking about it even more afterwards because they want to be alive to take care of their child. So I think it makes a lot of sense that those who became pregnant had longer survival. There was also data from Schechter and colleagues that looked at a big database that collected information about outcomes in CF, and it wasn't focused on pregnancy, but they did go back and look at those who became pregnant and actually show that they didn't have an accelerated disease progression, but they did have more exacerbations, more illness-related visits, decreased quality of life scores. And Tracy's going to talk to you a little bit more about what we know about parenthood in CF, because there are some impacts. So what do we know from historical data in the pre-modulator era? Well, there have been studies from large databases outside of CF that have looked at this and compared people with CF to those who don't have CF. And what they saw is that people with CF have higher rates of diabetes, infection, preterm labor, and gestational hypertension and preeclampsia. There are also more complications in infants born to moms with CF, including increased rates of congenital anomalies, particularly cardiac anomalies, jaundice, C-sections, and premature delivery. And there was a more recent look in the UK, and they actually showed that having a decreased lung function correlated with an infant with lower gestational age and birth weight. So we know that there were issues for both the mom and the baby in the pre-modulator era. Now, I don't want you to read all of this, but again, we're thinking about these people who are coming in with pregnancy. There are lots of issues that they may have just from the pregnancy, but they also have CF, and there are medications that we use in CF, and a lot of questions come up about whether or not you can continue those medications. And for the most part, there's a lot of data at this point that most of what people are going to take, especially the inhalation therapies, are just fine, as is Creon. The questions are about modulators, of course. And if you look at many of the guidelines that have come out, including those from ECSF, it shows that we think they're probably okay based on the data from animal models, but of course there hasn't been enough data collected to date. So what do we know about the animal reproductive models and these drugs? Well, this is sort of a busy slide. I tried to highlight those things that were shown when you gave supraphysiologic doses of the modulators. But at normal human doses, we didn't actually see anything in the animal reproductive models, which made the old pregnancy classification being class B, where we think it's probably okay, but we don't have enough data for sure to know. There was one study that I wanted to make you aware of in case any of your moms ask about it. So this group in France actually took out lungs of baby mice and exposed them to very, very high doses of Trikafta and said there's probably a problem with embryonic lung development. But again, this model is not at all the kind of models that we used in the reproductive question models in the studies before. This is a lung that's taken out and lots of Trikafta is put on it. So we don't actually think this is an issue, but it is something that we're going to be following in the Mayflower study. It's also important to realize that these drugs do actually cross the placenta. So the baby is absolutely going to be exposed. And this is data from Aaron Trimble's group showing that you can see levels of ivacaftor, tezacaftor, and elexacaftor in mom and infant blood. So for sure they're being exposed to drug, and during their pregnancy, they're being exposed at levels consistent with what the mom is seeing. But the question is, like, do you stop these drugs? This is work that was done by, again, Aaron Trimble and Scott Donaldson, looking at what happened when people actually stopped taking their ivacaftor. So you can see that there are 3 of these cases that they had really dramatic decline every time they came off of ivacaftor, and those declines were really sudden. And in fact, unfortunately, one of the persons actually died from loss of their ivacaftor. There were also, there's data from a phase 2 study looking at Alex-Tez-Iva, and that's when, of course, you were randomized to drug or placebo, and then you were just off drug before it got approved. And people had more exacerbations and lung function decline. So there is definitely a risk of stopping modulators. So when we think about medication safety, of course, we have to think about the balance, like what is okay for the mom and what is the risk to the baby, because there also are risks of mom having more complications and those drugs, as you heard in the last presentation, being a problem for the baby. So we have to balance those 2 things out. So because we understood that women were starting to get pregnant quite quickly after the approval of Trikafta, we went back and surveyed care providers across the world, mostly in the US though, in the case of Trikafta, but for Lumaiva and Teziva, and asked what happened to those pregnancies if the mom chose to stay on or came off her medication. And just summing up what we saw in those 3 different drugs, so in 135 females with CF, use of CFTR modulators during all or part of pregnancy resulted in only 4 maternal complications that the clinician deemed related to modulator therapy. Really importantly, I think the miscarriage rate was less than 10%, which is consistent with what we see in the general population, where it's usually 10 to 15%. Also, as I sort of alluded to before, cessation of modulator therapy was a problem for a good number of the women, and they had to go back on because they had exacerbations when they stopped therapy. And there were no modulator complications in the babies that the doctors deemed related to the drug. More recently, Dr. Jane and I have looked retrospectively at charts, and mostly that's the research coordinators, of course, doing all the chart reviews, so thank you to any of the research coordinators in the room, that looked at the data from 11 different sites and collected information about what happened during pregnancy for moms. There were a total of 350 pregnancies and 271 people with CF. Their average age was around 28, and I'll point out that that's older than the average age of people who get pregnant in the US. So they're a little bit older. The average lung function was around 74, and their BMI was actually pretty good at 23.5. And most of these women were not on modulators. And you can see that on the top graph, there were changes during pregnancy. And so people's lung function did go down. And that actually, if someone was on a modulator, was mitigated. Also, we didn't see a difference in pulmonary exacerbations in this case. It didn't reach statistical significance, but there were also changes in BMI. And again, people did better if they were on a modulator. Again, I mentioned unplanned pregnancies. So there are lots of unplanned pregnancies. There were some before Trikafta. There are more now. But it's a problem because those people who have unplanned pregnancies don't have as good of outcomes as you might expect as those who plan their pregnancy. So what we saw when we looked at those who were unplanned was that they were actually a little bit older, their lung function was, a little bit younger, their lung function was worse, and their BMI was definitely a little bit worse, and their outcomes during pregnancy, were a little bit worse. So we really want to counsel people again about unplanned versus planned pregnancies because it does make a difference for outcomes. And what about looking at the babies? So again, we see that there's a difference in the preterm labor. There's a difference in the C-section rate, and APGARs were also a little bit lower in those who were unplanned. So that brings me to the Mayflower study. So all the data that I've shown you so far has been retrospective. The one we just looked at had multiple sites in it, but a lot of the data that we've had previously is from single sites. And so we really wanted to, for the first time in CF, look prospectively at what was happening in pregnancy. So in this study, we're actually trying to capture moms as soon as they become pregnant, but we'll take people up to their third trimester, and we're following them through pregnancy. And then importantly, we're also following them and their infants after pregnancy, because there's really not a lot of data outside of that immediate time period of birth that I showed you in those database studies. We don't have data on what happens to the babies of moms with CF. So we're following them out to 2 years after the pregnancy. Also, we're doing 2 sub-studies looking at what happens with glucose metabolism during pregnancy, and we're measuring pharmacokinetics of the modulators for moms who choose to stay on their modulators. So these are all the different outcomes that we're measuring. Our primary outcome is really looking at lung health by percent predicted FEV1 and pulmonary exacerbations. But we also want to look at weight because that has been a problem. Weight gain during pregnancy has been a difficulty for a lot of people in the pre-modulator era. We're looking at all the pregnancy complications, which I told you are higher historically in women with CF. We're looking at surveys, including looking at their mental health, which again is a huge gap in the literature. We know that women are at risk for postpartum depression, and there may be reason to believe that people with CF would have a higher risk because of all of the other things that they're dealing with during the immediate postpartum period, including taking care of their own health. We're also banking blood at each visit, which is important because that means that you guys who come up with great research ideas can reach out to us once this study is over and apply to use that blood if you have a really great idea about things that we should look at that we didn't look at during the study. We're going to be looking at the obstetric outcomes, and of course, as I mentioned, we're going to be following these babies and making sure that they're actually doing okay as well. So for those of you who were able to make it, Raksha showed some of this data yesterday or maybe the day before. I don't know. It's a long conference. But we do have the full data set that she actually showed. So if you want to go back and watch all of that session, you can see all of the data. But I'm just going to show you a couple of slides. So again, with the demographics, I think it's important to point out, again, these women are older than those in general in the U.S. that become pregnant. Also, we are trying to work on recruiting more diversely, but we haven't quite reached the levels that are the proportions that we've seen in the registry. So we do have some diversity, but we have to do a little bit better. So again, if we're doing this at your site, please keep that in mind because we really want the results to be representative of everybody in the U.S. in proportion to their presence of the CF population. In terms of genotype, it's about what you would expect, the majority having at least one copy of F508del. And then in terms of diabetes, again, we know that 30 to 40% of females with CF do have diabetes as adults, and so we are seeing that here. We also, because of mostly, I think, Trikafta, are seeing really good BMIs in this study, and then their baseline lung function, as we've seen in some previous studies, is actually pretty high. Although one of the things that's quite different about this study than we've seen in the past is that we have people as low as 28, and that's somebody post-Trikafta. So people who have very severe lung dysfunction are actually able to not only get pregnant and carry those babies to term now, which is quite different than it was in the past. So what's happening with people's lung function? So of course, we're not finished enrolling this study, so it's early data. And if you look along the very bottom, you can see the number of people for whom we have data at that time point. So when you get out to 7 to 9 months, you see there are only 36 people who contributed data. So that's the caveat. But fortunately, we're not seeing huge changes, at least not huge drops in lung function during pregnancy, although again, I think as you might expect in that immediate postpartum period, you are seeing a drop in lung function. There are lots of things happening. For those of you who have kids, people aren't sleeping. It's probably hard to get in a lot of therapies when you haven't had any sleep and you're also trying to breastfeed. So that's not very surprising to us. What we were hoping to see is that for all of the people and not just those first 36, that it's actually recovering over the first year of pregnancy. So I told you I would get to mental health because it hasn't really been looked at very well. So we did actually do the PHQ-8 and GAD-7 for the people in this study. And you can see that there is a baseline level of anxiety that goes up a little bit, but we're not seeing a lot of people who are having horrible anxiety. We put the lines in there so you can see significant, mild, moderate, and severe. And there are some people who are reaching that severe range. And so we do want to follow up and see what it is about that particular pregnancy. Is it the pregnancy itself? Is it that they're not having enough support around them? So we do want to figure out why there are some people who are having really severe symptoms, both in terms of depression and anxiety. One other quick thing I wanted to mention in the last few minutes is what about treating babies? Because this is coming up a lot. I was having a conversation with somebody a few days ago, and I had been asked to write a review article for CHEST, and one of the things I did was present this case where oh, what if this happens, where a mom is pregnant and she finds out that she has a baby with CF, should we treat her? And people were oh, that's never going to happen. It's happening a lot. And so it's a discussion that we're really trying to figure out, how do we capture this information? So of course we have approvals of ivacaftor down to 1 month of age in the US, and for Lumivit down to 1, and ETIs now for 2 years and older. But there are these reports. The first one was by Sylvia St. Pettery down in South Carolina that described a mom who was diagnosed, or her baby was diagnosed with meconium ileus in utero on prenatal ultrasound, and her doctor, in conjunction with that woman, elected to treat her, even though she didn't have CF, she was just a carrier, with ETI in order to treat the baby, and it actually worked. So the baby was born without the meconium ileus and then avoided surgery in that way. And there are numerous cases of that at this point. And in fact, there's another case that I'll get to at the bottom because I'm running out of time here, where a male infant was actually he was again diagnosed in utero. Mom was treated with ETI throughout the pregnancy, and he was born with a palpable VAS. And so his family, in conjunction with his doctor, elected to use some Trikafta that fell off the truck to treat him to maintain his VAS. And to date, so far at 18 months of age, he still has his VAS. Of course, we don't know yet whether it works, but it's there. So this is really exciting, and I think we need to collect more data on this so we can actually advise people how to do this in a more organized fashion. So really quickly, one of the other questions that comes up, is it safe to become pregnant after transplant? Most transplant centers really discourage this because you have to be on medications that we know are harmful for the fetus. And if you stop those medications, you are going to be at high risk for rejection of your lungs. So if people become pregnant, we know that their complication rate is really quite high. So it does behoove you, if you're sending someone for transplant evaluation, to have this discussion with them ahead of time and maybe talk about other options besides becoming pregnant themselves. And then I'll just run through this really quickly. We'll skip through. It does go into breast milk as well. We know this from data from Erin Trimble. And from our study, we actually looked at those moms who did breastfeed while they were on ETI. We didn't see any cataracts in those babies, but only 6 of them had formal assessments. There weren't any modulator-related LFT abnormalities in those babies. Recently, we worked with Dr. Jane and Michal Steinberg from Israel, worked to look at babies who were all sent, so 23 babies were all sent to get formal cataract evals, and 3 of them had very small, clinically insignificant cataract evaluations. But the issue is that we don't really know what that rate is because most babies are not sent for cataract eval. And so that's another thing that we're going to continue to follow, and we're asking moms to do that in Mayflowers, although they don't have to if they choose not to. So one other quick thing to say is that there is a guideline. I don't expect you to read this, but I just want you to know that there are guidelines that we put out as a sharing group in conjunction with some obstetrics docs that talk to you about what you should do, the checklist that you should follow for people who become pregnant. So with that, I'll just conclude and say females with CF do have reproductive anatomy that's very similar to that of females without CF, but highly effective modulators do work on the cervix, and so counsel your young women about this. In the pre-modulator era, females with CF became pregnant and their infants did have higher rates of complications, so we're going to continue to watch for this during the modulator era. We don't see toxicity from animal reproductive models for those animals that were exposed to Trikafta during pregnancy, but again, we're following this during Mayflowers. There was a retrospective study who showed that females with CF who used modulators during pregnancy actually did quite well, and their babies did as well. But the Mayflower study is really going to hopefully definitively answer these questions, and hopefully they'll have some data from the UK too, from another study that we hope gets funded. So thanks to all the people who contributed to the data, the people with CF who use their voices to help us design these trials, and all of you who are actually sending data in for us. So thanks, guys. You guys want to take questions, right? Yeah. Okay.
That is exciting stuff. Next, we'll have Dr. Tracy Kazimierski come up. She's an assistant professor at the University of Pittsburgh School of Medicine in the Department of Pediatrics and Division of Adolescent and Young Adult Medicine. She's a pediatric pulmonologist and health services researcher at UPMC Children's Hospital of Pittsburgh and serves as the chair of the Institutional Transition Task Force. Her research centers on the improvement of comprehensive health care for adolescents and young adults with pediatric onset chronic disease. As vice chair of the CF Foundation, TDN, Sexual Health, Reproduction, and Gender Research Working Group, her current project focuses on improving the sexual and reproductive health care of people with cystic fibrosis. So please welcome Tracy.
Thank you. Thank you so much, and thank you so much to the organizers for the opportunity to present today. I'm going to talk about what it means to be a parent with CF, and the disclosures that I have here, the Cystic Fibrosis Foundation and the National Institutes of Health are funding this work. And I want to just start here, especially in light of the fact that we've heard a lot about pregnancy so far, but there are many ways to become a parent when you have CF, and all the options presented here have been pursued by our patients and families: pregnancy, adoption, step parenthood, foster care, and surrogacy. Jen showed this slide, so I'll go quickly through it, but the majority of males are infertile, they don't have a vas deferens, and they require assisted reproductive technology to have biologic children. As Jen went into great detail, females with CF may also experience this subfertility and require ART. For males to have biologic children, they must undergo sperm retrieval. And this is either via an open surgical approach from the epididymis or the testes, or through the skin using a needle via aspiration, again from the epididymis or the testes. After sperm retrieval for males, the sperm is combined with an egg and then implanted either using IVF or IUI. And for women who are experiencing subfertility, as you heard in the video, IUI is an option, and also many require fertility medications and IVF. But just coming back to this, building a family is complicated when you have CF. And in interviews that we've done with people with CF and their families, they've really reflected on the questions they have around, is parenting and pregnancy impacting my health? How is CF impacting my family and my relationship? Am I going to need ART? And what is the cost and availability of those different options? They think about what the support of their family is and the support of us as the CF team. And I think a big question is, what is the impact of CFTR modulators when you're a parent with CF? So there's not been a lot of studies that have looked at the outcomes of parents who have cystic fibrosis. A few years ago, however, we looked at the United Kingdom CF registry, and we took data from 2015 to 2019 on 296 parents. In the UK registry, they collect data on if you yourself have been a parent through pregnancy or if your partner has. We evaluated the impact of having a child on health in the year before becoming a parent, to the first year following parenthood. And this is what we found. There was a significant decrease in lung function and in BMI, and a significant increase in pulmonary exacerbations between those two time points. But what we also found is that CFTR modulator use really mitigated parenthood impacts on FEV1, but not on BMI and pulmonary exacerbations. This is a retrospective study, and it has a bunch of limitations. This was not done in the era of widespread, highly effective modulator use. It didn't include other paths to parenthood besides a person's pregnancy or their partner's pregnancy, and it really only looked at that first year following the birth of a child. So this is short-term outcomes only. So as Banksy said in his South London work, there's always hope. And indeed, the health outcomes of parents with CF, or HOPE-CF study, is going to seek to determine the health impact of parenthood on people with CF in this era of CFTR modulators. The next slide is super busy. We're going to spend some time on it and walk through it, so just a disclaimer. I want you to focus on the arrow in the middle. That's parenthood. And then you can see it's pointing toward parental health, and you can see that big plus minus there. And I think that when we think about how parenthood is impacting health, you can think about it from a bunch of different perspectives. And in looking at literature from the general population, those without CF, we've thought about this through sociological lenses, evolutionary, and biomedical. From a sociological perspective, you can experience a change in your support network, your family dynamics. You can have a strengthening of your social control, and it can really influence role strain, or how you see yourself within the world within your family. Children can have an impact on your overall joy and a sense of fulfillment, but it can also have an impact on mental health and depression and anxiety. There is data that parenthood accelerates aging. And also, indirect effects, which we'll go into in a little bit more detail on the next slide, can have to do with female hormonal changes associated with pregnancy, childbirth, and lactation, children as a source of stress or illness, and impacts on physical activity. Playing into all this is what is your sex, your gender, your age, your socioeconomic status, how you became a parent, the number, age, and spacing of your children. So this is complicated. And then you can see at the top in the gray box, you throw CF on top of it. And that's what we're really trying to understand. So I said I'd go deeper into this biomedical perspective. And I think, again, in the general population, we know that female hormonal changes during pregnancy, childbirth, and lactation are associated with increased risk of cancer, diabetes, depression, infection, and cardiovascular disease. I have 2 boys, and they are stressful sometimes. And kids are germy. As a pediatrician, I feel like I can say that. And they're a source of illness, and they bring home a ton of stuff from daycare, from school, from their friends. This is a bit of information that I found fascinating, really rang true to home. They did a meta-analysis of physical health in parents. Again, this is the general population. And they found in this study that parents are less active than non-parents, mothers are less active than fathers, and there was an inconclusive relationship between the number, the age of your children, and your marital status. So as I said, in the HOPE-CF study, we really want to understand the impact of parenthood on health. In the first part of the study, we're going to do this retrospectively. We're really going to look at the pulmonary health of people with CF and try to examine the impact of CFTR modulators. This is currently enrolling at 8 sites in the US, and we're looking at parents with CF as well as non-parents with CF. We're going to give them a very short parenthood survey just to understand if and when they became a parent and what that path looked like. And then we're combining that data with CFTR or CFF patient registry data. You can see that our main outcome that we're looking at is lung function. And our key hypotheses are in that comparison box there. We think that parents are going to have more rapid lung function decline compared to non-parents, that mothers may have more rapid decline compared to fathers, and that CFTR modulators may mitigate these impacts. We're also going to look at pulmonary exacerbations, hospitalizations, if you're coming to clinic, BMI, diabetes control, and your microbiologic profile. I think importantly, as you can kind of see in the Mayflower's data, there may be these critical periods that are harder than others. So we really want to look at that first year and the first 2 years when they're in preschool and swapping germs in years 3 to 5, and then following when they start school in years 6 to 10, if we can follow them out that long. We're going to consider a parent's sex and gender, their modulator use, their socioeconomic status, and again, that parenting path. So I'm hopeful that next year at NACFC, we'll have some more data to show you about what this analysis shows looking back in time. So aim 1, what I just showed you, is really looking at parenthood and impacts on physical health. But we know it's more complicated than that. And this is another busy slide. But we really want to look at parenthood and getting to pulmonary health, but all those things in between. We know that there's an interrelationship. Sorry, I want to see if I can do a pointer. I don't know if I can. Maybe. I don't think you can see that. We know that there's a relationship between your pulmonary health outcomes, your quality of life, mental health, depression and anxiety, and adherence, and it goes around. We also know that modulator use has impacts on this. But when we think about parenthood and how it impacts this circular axis, we also really need to consider, what are your responsibilities as a parent? What stress does that give you? What kind of support do you have? Are you sleeping? Again, down at the bottom, you can consider all these potential confounders. So we really wanted to design a study that not just looks at that linear relationship between being a parent and your physical health, but looking at everything that comes into this picture. So in the second aim of HOPE CF, we're going to try to prospectively evaluate health outcomes of new parents with CF and identify modifiable factors that may influence parenthood's impact. We hope this is going to start in spring of 2024, and we're going to be enrolling at 18 US sites. These are going to be about 150 new parents with CF of children less than age 5, again, via pregnancy, adoption, foster care, surrogacy, you name it. We're going to follow each parent out for 5 years. And we're going to look at survey data to assess, as I said, all of those things that we showed on the slide before. We're going to collect objective health data associated with their clinic visits. We're going to collect pharmacy refill data around modulators to understand their adherence. And you can see some of the hypotheses that we have here. Oops, sorry. We think that depression matters and that parents with moderate or severe depression may have worse outcomes than those with mild or no depression. We think that the level of parental responsibility and stress matters. So if you have more of those, you may have more rapid lung decline. And finally, we do think the modulators are going to impact this. And those who are using CF modulators, especially highly effective forms, may not see the negative impacts that others may. Again, we're going to look at not just FEV1, but all these other outcomes. And I think importantly, we're going to do interviews with a subset of these patients, because the numbers can tell you so much, but interviews, especially dyadic interviews, which is with the person with CF who's the parent, as well as their key partner or support person, are going to tell us what we need to do next. So we'll be able to get a sense of the lived experience as it's going on in the age of highly effective modulators to get clues as to what we should do and how we should intervene. And that really brings us to, what does the future look like? And my hope is the results that we get from this study can really aid those with CF in deciding if and when and how they want to become a parent, and help us as providers in sharing evidence-based guidance and counseling our patients and families. I think the ultimate goal is really to develop and test future interventions to prevent any hypothesized health decline these people may experience, and place them appropriately in time so we can target those high-risk periods of poor health outcomes. We may be needing to adapt clinic structures, including visit frequency, use of telehealth. bolstering psychosocial supports such as peer and family networks, or strengthening adherence through unique behavioral interventions specific to parents. But what can the present look like? And recently, we conducted an interview study with parents with CF, seeking to better understand their lived experience as a parent and what they want and need from us as CF providers. And these are the key themes that came out of those interviews. They shared that they need to prioritize their care routine while balancing their role as a parent, that it's important to delegate specific tasks or roles to partners or extended family, and that can help alleviate conflict. They desire support and resources specific to parenting decisions from their CF care team. They reflected that while it is logistically and emotionally difficult to avoid illness transmitted from their kids, infection risk can be mitigated by taking some precautions. And then last but not least, they were very clear that they wanted clinic-facilitated connections with other parents with CF to share strategies and experiences and for emotional support. I want to focus on this theme, how they want support and resources specific to their decision to become a parent from us. And I gave a talk yesterday that really highlighted the model of reproductive justice. And this is this comprehensive human rights framework for everyone with 3 core values. You have the right to have a child, the right to not have a child, and the right to parent a child or children in a safe and healthy environment. When you're a person with CF, or when you're any person, your goals can contain parenthood through any means. One of those paths is through pregnancy, or you can want to avoid pregnancy and avoid parenthood through use of contraception. And this is really key for us to do as a CF team because we are de facto PCPs. People want us to talk about this. As a pediatrician, I talk about it with my teen patients. And people with CF don't have PCPs. 41% of adult females with CF did not identify a PCP in a large survey of women with CF ages 25 and older. And more recently, 47% of males with CF don't identify a PCP. And this data analysis is ongoing, but it's presented in an abstract here. I presented this yesterday too, and I think I just want to go through it in a little bit more detail today. When you're talking to people about what their reproductive goals are, it can be daunting. And I think it's helpful to really frame this for everybody in the same way. The Power to Decide is a nonprofit that espouses the idea of one key question. So asking this question, would you like to be pregnant in the next year? But I just told you there's a lot of different ways to become a parent when you have CF. And half of our population physically can't become pregnant. So I ask these questions. Would you like to become a parent in the next year? Or would you ever like to become a parent if you have a younger person in front of you? And when you walk through what people can say to this, there's 4 possible answers. Yes, no, I'm not sure, or I'm okay either way. If they say yes, you can inquire about their pregnancy desires. If they or their partner want to become pregnant, you can engage in preconception care and counseling and fertility counseling if it's necessary. If they say no, it's really talking about those other paths to parenthood. If they don't want to become a parent and they're at risk for becoming pregnant, you really want to give contraceptive counseling. And most importantly is this bottom box, because this idea of uncertainty or ambivalence around family planning decisions is extremely common. It is common in people with CF and it is common in people without CF, and it is totally valid. So I think in that situation, we really need to be able to say, how can I support you as you walk that path? How can I support you in the decision that you're thinking about? The CF Foundation has wonderful relationship-centered communication resources in general through the Partnership Enhancement Program, or PEP program. But they have one specific guide on family planning and CF and reproductive goals. And it uses those key groundwork communication skills and frames it within that parenting conversation. So I encourage you to check that out. It's on mycff.org. And I want to end by saying, importantly, you may be thinking as a PT or an RT on the team, maybe this isn't your job. But I would specifically encourage you to consider that often you have incredibly close relationships with your patient. And due to the hands-on nature of your work, many people with CF just highly trust you and value your opinion. So you may find yourself in these conversations and a unique opportunity to be talking about this with your patients and their families, and then help foster and advocate for broader discussions with the CF team. And I'll end there. I want to thank the CF Foundation for supporting this work, the Sharing Working Group, and the members of my lab who help me do everything. But most importantly, I want to thank all our patient partners and our research participants. Without you, there's no reason to do any of this. Thank you so much.
Well, our last speaker, I'm pretty sure came the furthest to be here to talk to us. Dr. Brenda Buttons comes from Melbourne, Australia. I believe the home of Olivia Newton-John. The home of Olivia Newton-John, I believe, if any of you even know who that is. She began her career in respiratory medicine, physiotherapy in 1990 at the Royal Children's Hospital in Melbourne. And the Royal Children's Hospital is one of the largest pediatric CF units internationally. She completed her PhD at the University of Melbourne in 1999, undertaking practice-changing research on the effects of head-down tilting in physiotherapy on infants. She is now employed by the Alfred Hospital in the Department of Respiratory Medicine, working in the adult CF unit, managing around 370 adult patients. She continues her research in adults with CF pre and post lung transplant. I can go on because she does everything. And also she was one of the first person who, when I came to my first conference about 20 years ago, I signed up for her class, and she's amazing. And ever since then, I've considered her of high esteem. So please welcome Brenda Button.
Thank you for that incredibly generous and kind and warm welcome. I guess, like Jennifer said earlier, that just also means we've been around a long time. But thank you very much for this invitation to talk deeper about what we as RTs and PTs should do. How many of you in the audience are RTs and PTs? Hands up. Excellent. Okay, thank you. And I will now attempt to, the mouse, there we go. I have no disclosures related to this presentation. And my objectives are to talk about pre-pregnancy physiotherapy planning, what optimal airway clearance techniques we might use with these patients of ours, modifying exercise, positioning during airway clearance, and limiting some of the common issues, musculoskeletal problems, challenges in late pregnancy with physiotherapy and delivery, and then being a parent, mothers and fathers, how as the therapists do we support these people. So in the pre-pregnancy planning, as has been highlighted today, that's really important whenever it's possible, but it's not always possible, particularly now that we have a number who are having unplanned pregnancies. But at that time, we're hoping to discuss the patient to discuss all the relevant things with the whole multidisciplinary team, looking at their lung function status and what comorbidities they may have that are going to challenge them during pregnancy, and what medications are safe as they lead into becoming pregnant, as well as during pregnancy and lactation. And as we have some of our most illustrious researchers here in the room, that optimizing preconception health status is really of key importance. So what are we going to be doing in that pre-pregnancy planning phase? Well, the first thing is really to optimize airway clearance therapy, because many people come and say, oh, I don't do anything regularly, or I just do exercise. That's my main airway clearance. And of course, exercise as airway clearance during pregnancy is not very practical, because they're not going to be able to do it at a time when or effectively at a time when they really need it in later pregnancy. So this is the key time to say you really need to learn to be able to do something, because you're going to be wanting to look after your baby. And when they think about it in terms of, I'm doing this for my baby, they tend to see it in a new light. We need to talk about what's going to be appropriate physical exercise as pregnancy progresses, and the physical changes that impact on the lungs, which is of great importance here, and what the upward pressure of the growing fetus does to lung function and sputum, and then also helping prepare for motherhood and fatherhood from a physical point of view. And of course, education is one of our key roles during this whole process. And more frequent multidisciplinary visits are often recommended. And with all of those, all the members of the team are going to be practicing education. So these are some of the relevant things that therapists should know themselves, but also be able to impart some of this knowledge to our patients as to why they might be feeling certain symptoms at the time, which often are just normal for pregnancy, but because they have CF, they want to often blame it on their CF. So in turquoise highlight, those are the volumes that go up during pregnancy, tidal volume and inspiratory capacity, because you need more oxygen to oxygenate this baby. So the mother's going to be taking in more air. And then the ones that go down in yellow are all the volumes that are affected by the upward pressure of the growing fetus. Room has to be made somewhere, and in total, the woman will lose somewhere around 200 mils of her total lung volumes, and that's just because there's not much space there to take normal deep breaths. Then we need to think about the diaphragm. That's raised by about 4 centimeters, all caused by this upward growing baby. And the respiratory rate remains unchanged. The chest diameter increases by about 2 centimeters on average. And the subcostal angle increases because, again, it's got the chest wall has got to stretch around the baby. And so you get a much broader angle, so you don't get such good support for reflux, because that's one of your anti-reflux barriers. Huge changes in the cardiovascular system, which is important for them to understand, because again, sometimes those symptoms they think are CF related. All that increase in cardiac output and circulating blood volume, increase in heart rate. And because of all of these changes in that department, pulmonary hypertension is generally regarded as a contraindication. And of course, pregnancy-induced hypertension is common as well. So the upward pressure of the fetus as it's growing leads to lower lobe atelectasis. So you have literally the baby pushing up against the bases of the lungs, and you are actually squeezing those airways of the bases together and getting mucus plugging. And this mucus can become very thick and sticky and adherent and has what we would call the Velcro effect. It can really gum up the bases. And that can lead to difficulty in clearing secretions and drop in lung volumes as a consequence. And as the baby keeps growing further from the second into the third trimester, of course, this all just becomes more of a problem. So what can we do about it? Parents want efficient airway clearance techniques. They want ones that are going to work really well and that are going to be quick and easy to do. And our PEP, positive expiratory pressure, and oscillating PEP devices that can be combined with, say, hypertonic saline, which many of our pregnant women will be using through the pregnancy, no side effects there. Many will continue to use their pulmozyme as usual. But the combination of PEP or oscillating PEP with hypertonic saline really makes for a much more effective airway clearance technique. It's very quick to do. If a parent sits down and does it in an uninterrupted way, in 15 to 20 minutes you can have a really good session. And therefore, those combination techniques are really helpful. And there is evidence from Laub to say that when you do hypertonic, using it with PEP, you do get more deposition in the small distal airways where your problems are developing. When mums need more help, then the Metaneb is very useful, which now will be replaced. We don't have the Velara yet, but that will be the next device that we will find useful to use in pregnancy for some. This just shows the PEP devices, the PARI original plus the PARI PEP S with the blue one. They are good combinations, very time efficient and very effective as airway clearance. And then combining hypertonic with the Aerobica and using the AeroEclipse nebulizer is another very effective way of doing airway clearance and much liked by many patients. IPV using the Metaneb. We're not moving on. There's a video there we don't want to play, so we just want to move on to the next. How do we do that? Can you give us some help here? I just want to move on to the next one. IPV with the Metaneb using the CPEP or the CHFO, the continuous high frequency oscillation, very, very effective using hypertonic saline. Moving on then to gastroesophageal reflux in pregnancy. This wider subcostal angle, of course, adds to the problem and is very common in all people with pregnancy. Raising the head of the bed 15 to 20 degrees when lying down is helpful. Avoiding eating 2 to 3 hours before bed and always doing airway clearance before meals if possible, or at least 2 hours afterwards. Avoiding foods with caffeine that lower the lower esophageal sphincter tone. The dietitians will talk about this area. And avoiding all the bending over activities like tying shoes and, of course, head-down tilted physiotherapy, which luckily we left in the last century. So airway clearance we would be recommending in upright sitting for most women. Some of the common musculoskeletal problems that women face would be separation of the abdominal muscles with the diastasis rectus, rib pain from the upward pressure of the baby against the ribs, and then all your joints around the pelvis, the sacroiliac joints and the symphysis pubis, and of course then low back pain, carpal tunnel syndrome, and a referral to a women's health or to specialist orthopedic physiotherapists are often in order in this situation. So some of the treatment options for some of these common problems that we as therapists encounter would be postural education awareness for those increases in kyphosis and lordosis leading to pain, giving appropriate exercises, stretching, and sometimes massage. With abdominal muscles separating, we want to teach them how to do abdominal exercises in a correct way and avoiding making that separation bigger than it actually needs to be. And then strapping, particularly when they're weight-bearing around the pelvis, when they're standing cooking or being out walking, that can really be helpful in later pregnancy. And of course, encouraging rest whenever it's possible. So the old adage of don't stand when you can sit and don't sit when you can lie certainly applies in pregnancy. Daily pelvic floor exercises, exercising the type A and B fibers. So sometimes a women's health physio, it might be needed here. Many of us have already done some training in that area and can certainly manage it as a CF physio. And then night wrist splinting may be necessary if they're having carpal tunnel syndrome. That's particularly bothersome. Here are some pictures of some of the strapping that we might include in our treatments. And then the stretching of the intercostal muscles, which can either be done as free exercises or sometimes manually by another person, i.e. the Mary Massery courses. Many of us have learned from her how to do this manual intercostal muscle stretching. Sometimes we can teach the partner to do that, or the woman to actually do that for herself if she finds it helpful. Exercise during pregnancy should follow the same guidelines as women without CF. It should be modified. So, of course, contact sports would stop. Jogging, running, horse riding would be totally inappropriate for many reasons. Walking daily is highly recommended, as is swimming, cycling, as long as it's done safely and not on dangerous highways, and gym or Pilates that are held for special groups for pregnant women. Those are very useful, where the actual instructor is going to be giving appropriate exercises and advice. And for everyone, hydration is really important. Stress urinary incontinence, of course, is made worse with huffing and coughing, any of those downward pressure, sneezing, and of course also from the weight of the baby, stretching, leaning down onto that pelvic floor, causing problems with leakage of urine during pregnancy. So pelvic floor training should be done by all of us from puberty onwards, but particularly during pregnancy. So really focusing on that during pregnancy and post-pregnancy is something we need to be educating much of the time, and many women find life gets in the way and it's very difficult to get that done effectively, but it can really make a difference. Teaching of the NAC prior to coughing or huffing or sneezing, which is like bracing the pelvic floor, can make a huge difference to prevent leakage during airway clearance, or when you're going to have a cough or suddenly a sneeze is going to catch you. Endurance training of the pelvic floor muscles to meet the demands of these airway clearance techniques, as well as things just like spontaneous coughing when you're at the supermarket. When people have acute exacerbations, these muscles really suffer from fatigue, and fatigue makes them much less effective. Optimal positioning during airway clearance is important. Upright sitting with feet flat on the floor and a normal lumbar lordosis. This lass in the picture hasn't got her feet on the floor, so not exactly correct. But if you can be in that upright position, you've got much better lower bladder sphincter control. And teaching them to do the exercises. This is one of the recommendations from Women's Health, is type 1 fibers to pull up and hold for 3 to 5 seconds, and then to superimpose bursts of activity on contracting the muscle, pulling up, up, up. So you do that all in one big contraction. Pulling up and holding 3 to 5 seconds, up, up, up. And 3 sets of 10 is the recommended minimum dose. Some women need to do more than that to actually improve. And there are a lot of guidelines and advice in the International Physiotherapy Group for CF Blue Booklet on the ECFS website. You can just Google Blue Booklet and it'll come up. And then all of the different countries have guidelines with their organisations. For us, the Thoracic Society of Australia and New Zealand. So there are lots of resources, the CF Foundation, the European Society as well. Physiotherapy during labour. We know that normal women who have pain can develop shortness of breath and low oxygen saturation during labour. So if that happens with women without CF, it's obviously going to happen more with our patients who have CF, particularly if they have advanced lung disease. So we need to educate all our women that they may need oxygen during labour, because they might have 80% lung function and then be freaked out when somebody puts oxygen on them during labour. But if they expect that that's just normal, then that won't be a problem. Adequate pain relief, of course, is important. And ideally, having done some airway clearance before they go into labour, particularly if they're being induced, but sometimes they will need some bronchodilators and some mucolytics or even some clearance during labour if sputum is a real problem. That's becoming less of a problem for our women, of course, on our highly effective modulators. Vaginal delivery is desirable because we have minimize the complications afterwards. TENS may be useful, transelectric nerve stimulation. which can really help with pain management, and the usual support coming from partners or their various carers. If a cesarean section is required, which happens quite often, epidural may be appropriate. Adequate post-op pain relief is the most important thing for us if we're thinking about airway clearance and getting up and moving about afterwards. Oxygen therapy may be required, and again, bronchodilators, mucolytic agents need to be optimized. And airway clearance is a priority in this situation, particularly for somebody who has secretions and not on a gene modulator. IPV may be very helpful if they've got a lot of basal issues with mucus plugging and retained secretions. So there the Metaneb or the Volara would be very helpful. And sometimes BiPAP might be needed if the woman has very low lung function. Early mobilization, and particularly our role is to educate them how to get out of bed without causing excessive pain. And that's something that just needs to be thought about. And then contact with the multidisciplinary team in the postnatal period needs to be encouraged, and support at home should be talked about from the early days pre-pregnancy all the way through to afterwards. I've now got 2 case studies, one who was not on any gene modulators or CFTR modulators, just not suitable for her. She's a 31-year-old with a 5-year-old starting school. She has an FEV1 of 28%. She became pregnant without IVF the second time. She was advised not to with an FEV1 of 28%, but was not practicing contraception and wanted to be pregnant anyway against advice. So she considered this pregnancy as a miracle. There was medical counselling, but there was no way she was going to consider anything other than continuing with the pregnancy. She was highly and remains highly adherent to her treatment. She does PariPep with hypertonic saline twice every day. She finds that the most effective, and she sometimes also uses the aerobica with hypertonic with an oscillating PEP as well. During the 2nd and 3rd trimesters, she used to come to the hospital, and I was able to do weekly Metaneb with her, and she found that really helpful with getting ahead with the mucus plugging, and then for the rest of the week she could manage really well with her own independent home treatment. She demanded a vaginal delivery at 34 weeks. She just felt it was time to get this baby out. She thought the baby would be, of course, in consultation with all of her teams, but she did put a lot of pressure on the team to deliver her at 34 weeks. She was induced and had a healthy little baby, but he needed to be in the hospital for a while, and she stayed as an inpatient for about 5 weeks until he was ready to come home. He's absolutely thriving. He's now an 18-month-old. Her lung function has remained stable only because she's so incredibly diligent with her twice daily airway clearance and a walking program on her treadmill. But ever since this baby was born and before as well, anxiety has become a huge factor. And she's worrying so much about when's going to be the right time for her to have a lung transplant. She's clearly in that territory, but she has gone for quite a few years with very low lung function. So when is the right time? A very, very difficult thing that she's grappling with at the moment. The second case is a completely different picture. She's a 26-year-old who started with her pregnancy with Symdeco. She became pregnant with twins. Her FEV1 had been 70% when she became pregnant with twins. She had a hospital admission, and at that point they started her on Trikafta at 11 weeks pregnant. Her lung function increased to 80% FEV1, which she was very happy about. Her sputum, cough, and urinary incontinence completely ceased. So that's a story we do hear very often, that once they stop coughing, they stop leaking urine. So she was very, very happy about that as well. She continued the pregnancy with airway clearance with the aerobica and isotonic saline because hypertonic was irritating to her lungs, and she alternated those with PariPep and isotonic saline. So she did something every morning and every evening. She sailed through her pregnancy and an elective cesarean. Her babies are now 4 months old, and she's having to work on her pelvic floor. She has the opposite problem. It's not weak, it's actually too tight, and she has pain with sex. So she's seeing a women's health physio about that. And exercise as airway clearance with huffing and through walking daily is now her ongoing airway clearance routine into the future. So our role is very much to support the mother after the birth. As they recover from labor, we need to encourage airway clearance therapy for those who really need it. The ones who are on CFTR modulators may be able to drop it and focus more on exercise as airway clearance. We're not in a point yet of being able to recommend that, but sometimes we have to go along with what they tell us. If they say, I have no sputum, there's no way I'm going to be doing this, I don't have time. And sometimes we go along with that, but then we really need to monitor what's going on in terms of lung function and symptoms. She'll need assistance with care of the infant at home. Mother needs time for self-care, whether it's to go exercising, although often it's taking the baby for a walk in a pram with huffing. Many find that works really well for both of them. The combination of rest, sleep, and meals is really important, particularly in that recovery period after the birth. And whatever they are doing needs to be ongoing and sustainable. And often we will use telehealth visits because it's a lot easier to get to clinic on telehealth than to drag two twins to clinic. So then it leads us to care of parents in general, and particularly care of dads, because here we focused a lot on the woman, but what about the dad with CF who is going through birth as well? There was a nice study in 2019, I think from the UK, from Bianca Brook, on the implications of fatherhood on lung function and weight, and showed that there was a significant, small but significant drop in the year after having had the baby. So becoming a parent is a major life event, and fathers also need to support and to focus on self-care. We've already heard about this study from the author of the study with the registry, and again showing that the lung function can drop as well for both parents, and the BMI as well, small but clinically significant drop. So we can think about why might that be, what should these reasons for these drops be. Of course, adherence to various therapies can be part of it. Airway clearance needs to fit into a new routine for those who need to continue to do it, and we're not so sure with those on highly effective modulators. Physical exercise, often life gets in the way for mums and dads, but we were hearing earlier on that it's more for the mums than the dads in some situations. Sleep deprivation is a major problem. And then, of course, once they start going to daycare, childcare, exposure to viral pathogens is a major problem, bringing it home to the parent with CF. A case study of one of our dads who is a 28-year-old, very successful in the equestrian industry, married, living on a horse breeding and training farm, and his lung function was always, for years and years, about 45% FEV1. When he started Trikafta, his FEV1 went up to 62%, and that for him was a real game changer, because up till then, he'd never thought he could become a father. He didn't think he had good enough lung function to be able to bring a child into the world and then look after it for long enough to be grown up. But once he got onto Trikafta and became very stable and stopped having hemoptysis every time he was doing very fast riding, which he got from his incredibly high heart rate, that all stopped when he got onto Trikafta. And so that led to him saying, yep, I can become a dad as well. And he then went about the whole process with his wife of becoming pregnant and having a child, and this has been a great thing for him. And I think we're going to see this more and more with many men who'll have that same kind of thought after starting their modulators. His BMI has been stable. He still carries out his daily PyriPep with hypertonic saline every day because he's done that all his life, and he knows that he's still got some damage in his lungs and he needs to deal with that. Takes pulmozyme daily and rides horses every day to keep very fit. when I asked him what would be your advice to dads having a pregnancy and a baby, he said, I would tell them to look after themselves. I wanted to look after myself. I want to be around at the birth, and I want to be around as a parent, and I don't want to be a burden. And one of the things that I do in the outpatient clinic is invite them during the pregnancy, so the dads who have a pregnant wife, to bring their partner along to clinic with them, and for me to actually tell the partner how important it is for the dad with CF to be able to continue to do exercise, because you can imagine when he gets up and says, I'm going to the gym at 5 a.m, how she might roll her eyes and go, lucky you. Whereas if she knows that your health is your wealth, and have heard that from a health professional, it's much more powerful. So that's one of the things I always try to do in clinic, is encourage them to bring their pregnant partner along for one of the visits, so that I can tell them that, and then they see the sense in all of that. Outpatient clinics with telehealth are very helpful, and monitoring lung function, BMI, quality of life. We use the ALL score. It's a 1-minute quick questionnaire that tells us all about the 5 domains of wellness. And then many parents don't prioritize sleep. And Matt Walker's TED Talk, Sleep is Your Superpower, is the most fantastic 20-minute podcast to listen to. So I get them to download it in the clinic and suggest that they listen to it on the way home in the car, because that will really convince most people that sleep is actually a priority, not a luxury. We're going to have many more dads in the future. So having gone very quickly through a very large portion of life with lots of detail, we need to recognize that 4 out of 5 people with CF want to be parents. So this is going to be more and more what we'll be dealing with in our CF clinics. We'll be managing more mothers and fathers with CF. And we know that modulators have had a fantastic impact. We don't know exactly the fullness of what that impact's going to be in terms of pregnancy. I know we have had one young doctor who went through her whole pregnancy on Trikafta and did not ever do any airway clearance and did very little exercise, and she absolutely sailed through it. So is that the picture of the future? It's not something we're recommending, but that was her choice and that was the outcome. So I think the next years are going to be very interesting. But the ones who don't qualify for CFTR modulators, like the one my one case, we're going to have to be able to maintain acute rescue therapy skills for all these people. And in all of our interactions, a motivational interview approach is really helpful in developing good rapport and having good ongoing communication. Thank all our mums and dads who've taught us everything about what we know. They're our best teachers, and we thank them for the cases in this presentation, for their permission. And that's one of our websites in Australia, www.cfphysio.com. We've got some very nice podcasts from mums and dads that have been interviewed there as well. So you're very welcome to go and look at those. And those are my references, and thank you for your attention.
So we'll invite all of our speakers to come up, and we'll kind of have a panel for questions. There is a microphone on the far side of the room if you want to ask your question there. And then we've got a couple on the app. Here too. I'm having pains with it.
Is this on? Hi there. Thank you all for your presentations. I actually had a question about how you counsel mothers going through delivery and the pushing phase of delivery. We all tend to counsel our patients that we don't want an increase in the intrathoracic pressure and to avoid Valsalva, and that's not always possible when you're pushing. So what is that conversation like?
Can you repeat that? I'm afraid I didn't catch it all from here.
Sorry, I was just saying, how do you counsel your mothers who are preparing for a vaginal delivery when during the pushing phase to avoid excessive intrathoracic pressure? Do you advise them to push with like an open glottis, or is that something, are we worried about pneumothorax in that phase, or sorry, lung collapse, or just what are the considerations there?
Look, I think that's a little bit out of our hands, because once they actually get into the delivery suite, we don't have a lot of control over what they're doing. I mean, the things that we'd encourage them is to maybe be in as upright a position as possible. You're talking about like during the pushing phase, and if they're going to be pushing that baby out, I think if there's any risk that they're going to have a pneumothorax or they have very low lung function, often they end up going to an elective Caesar anyway. But I think, we've never had a problem. I've never heard of a woman actually getting a pneumothorax during pushing. Usually it's with big coughs, kind of intrathoracic pressure. In theory, it could happen, but I think it becomes a little bit out of our hands at that point in time. Whether they might, if they had a lot of bulle and things, they probably wouldn't be getting pregnant. But if that was the case and we were really concerned, I guess we could discuss with the obstetrician whether then maybe more of an epidural and a forceps delivery might be more appropriate. But I've never read anything on that happening, and I've certainly not come across it with any of our patients. And I'd be interested to hear from my other colleagues whether they have any comments.
Yeah, I would agree that we don't actually ask our patients to modify their pushing technique. It's for the people who have really severe lung disease, like Brenda said, they are going to probably end up going to C-section. And we do see a higher rate of C-section. I think it's partly because pregnancy causes dyspnea anyway, and then women with CF are even more dyspneic, and the OBs start to frankly freak out, and so they do C-sections a lot more. In people with CF, I'm hoping we're going to see a decreased rate in C-sections with people on Trikafta as the OBs become more comfortable, but we don't actually ask them to modify how they're actually doing their vaginal deliveries. But it's a good question.
Thank you so much. I have two questions. Sorry, is that okay? The first one was with the last presentation on exercising and contraindications for women that are pregnant, and I was just wondering. I know one of them said like no running or jogging. Is that more for like patients that are like presenting with other musculoskeletal issues, or because I've personally thought that like having people continue what they were doing before was acceptable. So I didn't know if there was any other like indications for that population.
No, it would all be for the musculoskeletal problems that it's likely to cause, because from quite early on in pregnancy, you get the ligaments are starting to stretch and they start feeling symptoms in their symphysis pubis and their sacroiliac joints quite early on. Within the first 4-8 weeks, people are starting to complain about feeling that's all happening, and they might have some pain. And if they're going to jog, some will continue to do it for a while, and some will continue to ride horses for a while. We read about these exceptional people, but in general it would be that they're going to probably bring on those musculoskeletal problems, particularly around those joints around the pelvis. That would be the main thing, and you don't want to end up not being able to walk very comfortably. You'd rather be able to walk vigorously for exercise rather than run and risk that. But that would be the point of view. It's not something that you can't do, but you'll probably find you won't be able to do it for very long.
Thank you. And then my other one, I'm not sure who it's directed to, but I'm in the outpatient clinic, and I've been asked by other providers to see patients when they come in that are newly pregnant or far along. And does anyone have any like resources or screening tools or devices that they use with patients coming into the clinic, for a 10 or 15 minute assessment? So this is probably for any of the PTs in here. If they're seeing patients in clinic, just for either like assessments or to touch base with them or to talk to them about positions to not avoid or to avoid.
We certainly use our OR score, our Alfred Wellness score, which is a 10-point, 10 questions question. I have a poster 446 has got all of that on it, or 447, if you want to have a look at the OR score. That's very useful in pregnancy because it goes through respiratory, nutritional, anxiety, sleep, wellness, exercise, and energy. So it's all those sorts of things. It's the 5 domains. And we find by running through that with the pregnancy, it takes a minute at the beginning of clinic. It's a useful one to follow. In fact, the lass that I talked about, the one who had the baby with 28%, in the end, she freaked out whenever she did lung function because it was low. And so she never wanted to do lung function. But having the OR score all the way through and seeing her staying stable with that week after week, that became one of our measures. But that is the one that we use together with lung function, BMI, the usual clinic things. But there might be others who've got.
So a part of Christina's education handout that she created for the OBG and the team, she asked me to create a handout for our patients regarding exercise. So it's just a little packet that I have, and I'm happy to share with. It just goes over contraindications, exercise recommendations, like a baseline of strength training, because a lot of my patients are strength training and they want to continue, and then a little fun facts about your pelvic floor and the changes that you go through that I'm witnessing myself at 30 weeks pregnant. So, yeah.
Hi, I have just a question that's not as respiratory PT focused, but I worked in MFM before I came over to CF clinical research, and one of the things we talked a lot about in MFM is regionalization of maternal care and perinatal care to sort of optimize health outcomes of moms and babies. But what we've noticed, especially in the Mayflower study, I'm the lead coordinator on that study at our site, is that a lot of our patients who are on highly effective modulator therapy are actually seeing OBs and MFM providers at more local centers closer to home than the tertiary and quaternary care centers that a lot of us practice at. So I was wondering what your guys' recommendations are for maintaining care continuity and coordination of care between CF and OB care teams, given a lot of our patients are seen outside of our centers, or at least at my site, they're seen outside of our center. So how we can kind of manage that.
So what we've done, and I'm sure we've all have this experience, but insurance also plays a big part into it. Some hospitals are covered, some are not. Some OBs don't deliver, they don't have preferences. So really creating that document that we have and we provide to the patients to give to their OB providers, MFM providers, and really having our contact information. I personally like to reach out when with the patient's blessing, of course, but I like to reach out and just be like, hey, it's me. Any questions? Can we do anything? Here's our last clinic note. If you need anything, please let me know. And just try to keep that line of communication open. And then the patient's a really good resource as well. So that's what we do in our clinic.
Yeah, and one of the things that really struck me when I think we were actually together when we were drawing the parenthood study on a napkin, there was a patient who presented, and her biggest frustration was the lack of communication between her OB and her CF docs. And so I take it on myself to initiate those conversations again with permission, just because that still sticks out in my mind about how frustrating that was for her. We also did establish, for those who can go in insurance-based or whatever close to Denver, can go to one person. We have a really good relationship with one person, so we try to have them go there. But if not, then we will reach out. I know Dr. Felton has worked a lot on this in the UK, and do you have a poster here, Imogen? What number is it? 565. Go see poster 565 because she's done a fabulous job in creating a CF sort of OB service to approach all the people that are taken care of with new pregnancies.
From Toronto Adult Clinic. So we have a lot of patients doing actual manual chest physiotherapy, the percussion and modified postural drainage. What do you think we should do when people who are pregnant and has become hospitalized? Sometimes they ask for a manual chest physiotherapist. What is your take on about that?
We have never practiced percussion on pregnant women because it's very uncomfortable, to lie down, they get reflux, it's uncomfortable. And we go for PEP, oscillating PEP, combined with hypertonic, and if they're really needing the big guns, then we would use IPV, Metaneb, Valara type system. But certainly that's something we would be starting early in the pregnancy, and I guess most of the world, if you look at our poster number 446, very small parts of the world are still doing percussion anywhere, and that was a worldwide study. So I think, we're all really thinking, is it not much more efficient and effective to empower women to do their own physiotherapy? They have to do that every day at home, and the time to really empower them and teach them and get them in doing a really good technique is when they're with us in the hospital, because they're captive and we have time to actually practice all these techniques, because they're tools and we have to teach them to become workmen of tools, the craftsmen. So we would always use our hospital admission time as a time to train them, and then we empower them to look after themselves. Just like diabetes and asthma, they want to be able to look after themselves and have as normal a life as possible. And that's why we've left percussion behind, because that relies on somebody to come and do it for you. You have to lie down. That makes you be a patient. You're not just a normal, healthy person who happens to have CF, and particularly now in the era of CFTR modulators, I think we've really got to think about empowering people to look after themselves. So that would be my response there. Thank you.
2 questions on the app that I'll read. The first question is, do you recommend HFCW therapy during pregnancy, maybe a wrap instead of a vest jacket?
I'll stand for the next one so you can keep answering.
There are not many countries outside of the USA who use high frequency chest wall oscillation therapy, and we certainly don't use it in Australia, and we certainly do not use it with pregnancy. So I'm not the right person to ask. There might be somebody in the audience who would like to stand up and answer that question. How do you do it during pregnancy? Because again, we're looking for a quick and efficient airway clearance. So for us, PEP, oscillating PEP, combined with hypertonic saline or isotonic saline is much quicker and more efficient, and that's what parents are looking for. And we're hearing about how they're all leaving their vests behind. So maybe we need to all rethink where we go with this.
I actually asked the patient. I do have patients who, when they get pregnant, don't want to stop using the vest. So we kind of moderate it a little bit. We, undo the bottom once they get too big. We change the speeds, the hertz and the pressure. Some people just want to keep doing that. Others, I push more towards the aerobica and have them do that with the hypertonic saline, and that seems to work. Again, with the modulators nowadays, less people are doing the vest. I hate to say this, but most of my patients are kind of walking away from the vest. So yeah, we've been able to get away with just the aerobica for those who don't want to continue.
One thing, and just to reiterate Brenda's point, there have been studies that looked at all the different modalities of the ways to do airway clearance, and none of them has been proven to be better than others. So it's perfectly fine for people to not use a vest and use a different form of airway clearance.
And if I were to choose between oscillating PEP versus positive PEP, straight PEP, particularly in somebody in late pregnancy who's got mucus plugging, I would go with the PEP and the hypertonic first, because you can get air in behind the secretions more effectively than maybe just with the vibrations and the oscillations. So a number of my patients who've been through pregnancy will say they find that the PEP combined with hypertonic is more effective in later pregnancy than the oscillating PEP. So just an aside there.
Okay.
Do we know if children with CF born to FWCF who were on Trikafta during pregnancy are healthier at birth than children who were not on Trikafta during pregnancy?
So if the baby has CF, it is most definitely healthier if it's been exposed to Trikafta. So pancreatic insufficiency develops in utero, and so these babies actually have false negative newborn screens if they're exposed to Trikafta because their pancreas actually works. And when you do sweat tests on these babies, especially depending how close you do it to the time that they were in utero, because once they're getting it through breast milk, it's a lot lower concentration, but their sweat tests are much lower than you'd expect. So it absolutely makes a difference for a baby with CF to be exposed in utero. They're much healthier when they're born. And in fact, if you talk to Chris Fortner, who presented yesterday, like both of his babies, not his personal babies, the babies of his moms, are off pancreatic, like they don't need pancreatic enzymes out to 18 months and 3 years of age and are incredibly healthy. So it does make a huge difference.
I was just going to add to part of the newborn screening is the IRT. And in our clinic, we actually reach out to the newborn screening department in Texas to automatically reflex those results because it just seems better for the family and with the parents, obviously, with their consent. But that's an option too, to just kind of bypass that.
Yeah, sorry, and I should have said that there is a guideline from the CF Foundation, and they're using it in Europe as well, that if a baby is born to a mom with CF, that baby needs to be genetically tested because we know that their newborn screen is going to be falsely negative, even if they have CF. So they really need genetics and a sweat test if there's a concern.
Do we have any other questions?
Okay, well then that ends our session. Thank you everybody for coming. Thank you for our esteemed panel. We appreciate everybody coming and have a good final day.